So right now, I mean, inside the skulls of up to 15% of adults, there's this really quiet structural collapse happening.
Yeah, and it's completely silent. Most people have no idea.
Right. The tympanic membrane, your eardrum, is physically caving inward, and it's often triggered by, a childhood infection that you probably thought you cured decades ago with, like bubblegum flavored antibiotics.
Oh, the classic pain medicine. Everyone remembers that.
Exactly. And because of that, the illusion of the simple earache is just incredibly pervasive. You view it as this transient glitch, right? Like a temporary error code that you just clear before moving on.
Which, I mean, it's a comforting fiction, but the reality of chronic otorhinolaryngology is far more relentless than that.
It really is. Welcome to our deep dive. Today we're looking at this incredibly dense but fascinating excerpt from Scott Brown's Essential Otorhinolaryngology Head and Neck Surgery, specifically Chapter 10.
Right, the chapter on chronic otitis media, which, for context, this text is basically the gold standard for surgeons who have to navigate the anatomical wreckage left behind when these infections just refuse to go away.
Yeah, so our mission today is to completely change how you think about ear infections. We are moving way past the simple earache and dissecting this chronic cascade that actively remodels the anatomy of your head.
Okay, let's unpack this.
Let's do it.
Because to understand how we reach the point of, bone-eroding complications, we have to start at the root cause, the etiology.
And we have to debunk a huge myth right off the bat.
Yes, the plumbing theory. Because the conventional wisdom, the mental model most of us have, is that we blame the eustachian tube. We assume the tube gets blocked, it can't drain, and the stagnant fluid causes disease.
It's such an oversimplification.
Right, it's like blaming a completely flooded house entirely on a slow drain in the basement. Like, surely something is generating water. Yeah, you can completely discard that slow drain theory for the general population. Unless a patient has specific craniofacial malformations, the text explicitly states there is just little evidence to support the idea of a faulty eustachian tube being the root cause.
Wow, okay. So if we rule out the plumbing, what's actually causing the flood?
Well, what's fascinating here is that figure 10.1 in the text maps this out, and it's a much more complex collision. It's early childhood bacterial ingress combined with a very specific host genetic predisposition.
So it's your own genetics betraying you, kind of.
In a way, yeah. In early childhood, the middle ear is constantly exposed to bacteria. Most immune systems clear it and reset. But if you have this genetic predisposition, that initial bacterial load triggers an exaggerated, localized cytokine cascade.
Meaning the immune system overreacts.
Exactly. The mucosa enters the state of chronic inflammation that simply never turns off.
The fire just keeps smoldering.
Yeah.
And that constant inflammatory state forces the tissue to adapt, right? Like specifically with the goblet cells.
Yeah, the goblet cells undergo massive hypertrophy.
Yeah.
And they don't just get bigger, they multiply.
Goblet cells being like the microscopic mucus factories.
That's a great way to put it. Under all this inflammatory duress, they increase in density and just start pumping massive volumes of hyperviscous mucin right into the middle ear cleft.
Which produces chronic otitis media with effusion,
Yeah.
or as it's more viscerally known, glue ear.
Glue ear, yes.
And the stats on this are wild. 5 to 6% of all children at age 2 have middle ears full of this thick glue-like fluid.
Right, it peaks in early childhood and then statistically it becomes pretty rare after age 7.
Right.
But the crucial part is the retrospective link.
Right, when you look at adults.
Exactly. If you survey adults suffering from severe end-stage chronic otitis media, the vast majority have a childhood history of glue ear. It's the initial biological dominant.
But the glue ear isn't just sitting there harmlessly, because if your middle ear is constantly filled with fluid like a swamp, what does that actually do to the physical structure of the eardrum over time?
Well, it depletes the oxygen, for one. And when gaseous exchange shuts down, things start to bubble.
So the lack of oxygen and the inflammation trigger, what, a disruptive breakdown?
Yeah, it causes lysis, or a weakening, of the fibrous layer of the tympanic membrane.
I think of the tympanic membrane like a trampoline. That fibrous layer is what gives the trampoline its bouncy tension so it can react to sound waves.
Right.
And these enzymes act like a harsh chemical solvent being sprayed onto the trampoline. They dissolve the collagen fibers.
So the membrane loses all its tension, it becomes flaccid, and because the middle ear pressure is often negative, that weakened tissue literally just gets sucked inward.
Right, which is the tympanic membrane retraction we mentioned at the start. Up to 15% of adults have this.
It's remarkably common. It usually affects the pars flacida at the top or the pars tensa.
And doctors use these specific grading systems to measure how far it's caved in, right? The toes and state systems.
They do, yeah. Table 10.1 covers them. They measure everything from a mild concavity to the eardrum, physically adhering to the tiny bones inside. But the text is actually pretty blunt about these systems. It notes that inter-observer reliability is poor.
Meaning doctors basically just argue over what grade it is.
Pretty much. It's super subjective.
Yeah.
A 2D microscope makes it really hard to judge depth.
So how do you even treat it if you can't agree on how bad it is?
You monitor it, mostly. But if there's a hearing loss specifically, an air bone gap greater than 20 decibels, then you need a cartilage tympanoplasty.
Rebuilding a trampoline. But why use cartilage? Why not just use like a skin graft?
Skin or fascia just isn't stiff enough. It would immediately get sucked right back in by the negative pressure. Cartilage, usually taken from the patient's own outer ear, is stiff enough to hold its ground, but still transmits sound.
That makes sense. But okay, a retracted eardrum is at least still intact. What happens when a weakened trampoline actually tears?
Back to tympanic perforation. And that changes the whole dynamic, because now you have a direct hole between the outside world and the sterile middle ear.
Which just invites constant infection, right? Like shower water or a cold.
Exactly. And when it gets repeatedly infected, it escalates to chronic suppurative otitis media, or CSOM.
And the numbers for CSOM are staggering. It affects about 1% of adults in the UK, but globally, 250 million people.
It's a massive global health burden, especially in socioeconomically deprived regions where access to specialists is rare.
And treating it sounds, honestly, pretty intense. Because there's so much pus and discharge, standard drops can't even reach the tissue.
Right, you have to perform what the literature calls an oral toilet.
An oral toilet, such a vivid, terrible phrase.
It is, but it's accurate. You have to use microsuction to basically vacuum the biofilm and debris out. Figure 10.2 even suggests rolling up tiny spears of tissue paper to whip the moisture out manually if you don't have a suction machine.
Wow. And then once it's clean, you use antibiotic drops. But the text points out something really specific here about quinolone drops, right?
Yeah, quinolones are the frontline defense. Because they're highly effective, and crucially, they are not ototoxic.
Right, because if there's a hole in the eardrum, the drops flow right down to the inner ear.
Exactly. You use something like lycoside drops. The molecules cross into the inner ear, kill the hair cells in the cochlea, and cause profound permanent hearing loss.
Which is terrifying, but quinolones don't do that.
No, quinolones specifically target bacterial DNA. They ignore the human cochlear cells entirely.
So smart. And then ultimately, surgery fixes the hole. A tympanoplasty has an 85% success rate, right?
Yeah, it's very effective at stopping the cycle.
Okay, but here's where it gets really interesting. Because a torn eardrum isn't even the worst case scenario. The nightmare is when the eardrum doesn't tear, but instead forms this deep retraction pocket that pulls normal skin cells, squamous epithelium right into the middle ear.
Right, this is cholesteatoma. It is easily the most aggressive disease in this entire chapter.
It's basically an invasive weed. Like, imagine a harmless ivy plant on the outside of your house. That's your normal skin. But if a storm blows a cutting of that ivy deep inside the walls between the drywall and insulation, it goes crazy.
That's a perfect analogy. Because inside the middle ear, the body has no mechanism to manage skin cells.
Right, because skin sheds, doesn't it?
It sheds keratin. On your arm, it just washes away in the shower. But deep inside a retraction pocket, those shed keratin cells have nowhere to go. They pile up and form this expanding encapsulated cyst.
And about 1 in 10,000 people get this every year. But it doesn't just sit there. It actively destroys the skull.
It does. The pressure from the expanding mass cuts off the local blood supply, which causes inflammation, which activates osteoclasts.
And osteoclasts are the cells that absorb bone.
Right, exactly. The cholesteatoma literally tricks the temporal bone into dissolving itself.
That is wild. And obviously, drops or pills won't fix a growing ball of skin. You have to do surgery. A mastectomy.
Right, you have to drill out the bone and find every single microscopic skin cell. And this brings up a huge debate in the surgical world. The wall up versus wall down approach.
Okay, so wall up, what wall are we talking about?
The bony wall of the ear canal. In a wall up procedure, the surgeon drills behind the ear but leaves the ear canal completely intact. Cosmetically, it looks perfectly normal afterward.
But the text says leaving the wall creates blind spots, right? Like you could leave a microscopic piece of the cyst hiding behind the bone.
Yes, residual disease is the big risk. So standard protocol used to mean a mandatory second look surgery a year later. They would literally open your skull back up just to check if they missed a spot.
Oh, wow. Just to check?
Yeah, but today we use specialized imaging instead, specifically non-echoplanar diffusion-weighted MRI.
Because it tracks water molecules, right? And water can't move freely through a dense mass of keratin, so it lights up on the MRI.
Exactly. It's brilliant. It lets radiologists spot microscopic pearls of residual disease without having to do a second surgery.
Okay, so that's wall up. What is the wall down procedure? Just remove the wall entirely?
Yep. They drill away the back wall of the ear canal entirely, merging the canal and the mastoid bone into one giant cavity. No blind spots.
But you're permanently altering the structure of their hip.
You are, and it creates lifelong morbidity. The ear can't naturally clear wax anymore, so patients need lifelong clinic visits for microscopic de-waxing.
That sounds awful.
It gets worse. Often surgeons have to do a medioplasty, where they purposefully widen the outside opening of the ear just to let enough air in so the cavity doesn't rot.
Oh man. So you're trading a hidden cyst for a lifetime of maintenance. But I guess if you don't do it, the complications of leaving the cyst are worse.
Oh, absolutely. If it keeps eroding bone, it hits the facial nerve, unilateral facial palsy.
Your face gets paralyzed.
Yep. And if it erodes inward, it hits the lateral semicircular canal. That causes violent vertigo and permanent deafness.
And what if it goes up toward the brain?
That's the extratemporal spread. You're looking at purulent meningitis, brain abscesses, or sigmoid sinus thrombosis, which is a massive blood clot in the brain's drainage system.
The text actually puts a number on this. A 1 in 10,000 risk per year of death just from the intracranial spread of this infection, from what started as an earache.
It's terrifying. But let's say the patient survives all of this. The infection's clear, the surgery's working. The text brings up one last thing: the permanent footprint left behind. Sclerosis.
The quiet aftermath. Basically the anatomical scarring.
Right. After decades of inflammation, the tissue just starts depositing dense calcium and bone matrix where the inflammation used to be.
If it's just on the eardrum, it's called myringosclerosis, right? Just look like weird white chalky patches.
Yeah, myringosclerosis is visually alarming to a new doctor, but it's mostly benign. It rarely affects hearing enough to matter.
But the calcium doesn't always just stay on the eardrum. It can actually engulf the little bones in the middle ear, the ossicles.
That's the real problem. The calcium acts like biological cement. It fuses the malleus and gluteus and stapes into a solid, rigid mass.
So you get severe hearing loss because the bones literally can't vibrate anymore.
Right. And surgeons will go in to rebuild the ear and just find the bones encased in solid rock.
Can't they just chisel it off?
You would think so, right. But the text specifically warned against this. If the stapes footplate is cemented to the inner ear, the surgeon often just has to abandon the procedure entirely.
Wait, really? They just leave it?
They have to. If you forcefully drill that dense bone off the footplate, the acoustic energy transfers directly into the cochlea.
Oh, and it destroys the hair cells.
Exactly. Right. You might successfully free the bone, but you'll cause a profound, permanent sensorineural dead ear in the process. It's just not worth the risk.
So what does this all mean for you, the listener? Well, a simple ear infection is rarely just an isolated event. For a lot of people, it's the start of a lifelong battle involving genetics, bacteria, and chronic inflammation that literally dissolves collagen and remodels your skull.
It's a brutal adaptation.
Yeah.
And it leads to a really unsettling reality about how we actually treat this disease in the clinic.
Right, because we talked about how cholesteatomas, those destructive skin cysts, form naturally from retraction pockets. But the text mentions a secondary pathway, the iatrogenic cholesteatoma.
Iatrogenic meaning caused by the medical treatment itself.
Right, meaning a surgeon's own instruments accidentally implanted normal skin cells deep into the middle ear during a previous surgery.
Think about the implications. You get a tympanoplasty or you take your toddler in for ventilation grommets to treat their blue ear, necessary surgeries to save their hearing.
But just the act of making the incision, of pushing a micro instrument through the ear canal, carries the risk of dragging a microscopic seed of skin into the dark space behind the eardrum.
And leaving it there to grow into a bone-eroding mass.
It's a crazy paradox. How do we balance the absolute necessity of these life-saving surgical interventions against the terrifying reality that the surgeon's own tools might inadvertently plant the seeds for a lethal complication a decade later? It's definitely something to think about next time you hear someone say they just have a simple earache.
Absolutely.
Thanks for diving in with us.